Hello, and thanks for joining us. My name is Matt Lineberry. I am at the University of Kansas Medical Center, and I'm very proud on behalf of our team to be able to share with you our analysis of the fundamentals of endoscopic surgery skills examination. Thanks very much to the SAGES 2020 Program Committee for making this virtual conference possible. Our disclosures are displayed here. Encourage you to pause if you'd like to review those more carefully. I do want to emphasize that these are our views, not our institutions, and big thanks to the SAGES program folks who helped us to have access to this de-identified data. We were very grateful to be named a Best Paper Award presentation for the SAGES conference, and the good news is that means the paper is actually already available. You have two links here. If you are not able to have access to the first, everyone should have access to the second. If you like, please pull that up, and any references mentioned in this presentation refer to the reference list in those papers. The context of our research is around the fundamentals of endoscopic surgery examinations meant to support objective assessment of whether trainees are ready to progress from training into practice. Those examinations have been developed for years, and starting with the 2017-2018 graduate cycle, those became required as part of setting the surgical board certification. There are two parts to the FES assessment, and those include a knowledge test, and then the focus of today's talk is about the simulation-based fundamental skill assessment. For any assessment validity, the property of measuring what's meant to be measured is a key quality criterion. Work sample tests like the skills exam have a very strong logic and evidence base generally, and this FES exam has specific studies in support of its evidence early on, and investigation should continue. We most recently conducted a study of pilot participants on the FES exam, finding mostly supportive evidence, and also some unique findings that we wanted to explore further in the current study, now that examinees are in fact required to complete FES for board certification. Details of our design and our participants are mentioned here. We had just a little bit over 2,000 participants who were required, again, for board certification purposes to complete the FES examination successfully. And this was de-identified data and so deemed not human subjects for IRB purposes. Details of our measures are listed here, and I'll let you pause and read over these for yourself. And the details of examinees completing the assessment are given here, again, for you to pause and read through. I will share a brief clarification, which is that depending on what test center you completed the exam, you would complete it on either of two quite similar simulators, just according to what that center has available. There had been a prior study that seemed to indicate that the GI Mentor Express, rather than the Mentor 2, was easier, or that scores were higher on that platform, and so a conversion factor was set to try to correct that. Our results for demographic variables are displayed here. Again, take a moment to review as you like. I'll simply draw attention to the relatively high pass rate, 83%, relatively high proportion of examinees using the Mentor 2 versus the Express. Most examinees completing this in the latter years of their residency, and you can see here the breakdown of gender, glove size, and hand dominance. Here we're sharing performance on each of the subtasks, and as you can see, performance is lowest by far for loop reduction. That is the most difficult subtask of the skill exam, and then proceeding in order of increasing easiness from there. Most all of those comparisons are significant. And if we look at the correlations between these subtasks, they're really pretty low for the most part, and coefficient alpha, which is a sort of meta-correlation, an internal consistency measure, was also pretty modest, suggesting these are different but related tasks. You would expect performance to increase as experience increases, and indeed that's evident, such that here you can see for lower endoscopic experience, specifically, the pass rate is quite high for those with large amounts of experience, and quite a bit lower for those without. Looking at pass rate on first attempt across some of the extraneous variables shows there are some rather large differences. Men passed at a rate of 92% versus 71% for women. Also a very large difference by glove size as shown here. A perhaps significant practically difference by handedness, although that is not statistically discernible. And then by simulator type, performance and pass rate was higher for those using the Mentor 2. Each of those differences on the previous slide is worth digging into. One hypothesis that had been shared with our team about the difference by simulator type was perhaps because the Express isn't height adjustable, people at different heights might be having issues with it. We didn't see evidence of that. We did wonder perhaps there simply shouldn't be a conversion factor, essentially a penalty for the Express, and indeed if you just remove that conversion factor, then scores are practically equivalent. Important to note, gender, height, glove size are essentially inextricable. They are very highly correlated with one another. We did conduct a combined analysis of logistic regression to predict pass status. Two significant predictors emerge from that, one of which is gender. Men have 3.2 times the odds of passing as women. That's not the same as saying they're 3 times more likely to pass, but their relative odds are quite a bit higher. And then for each increase in lower endoscopy experience, the odds of passing also increase fairly substantially. We explored whether the differences by gender varied by experience level, perhaps that as experience increases, that effect diminishes. We did not find evidence of that. There was no discernible interaction between experience and gender and their influence on scores or pass rate. Reflecting on our findings, as expected, experience relates to scores and to pass rates. As found previously, these subtasks are really distinct. It's not a single skill we're measuring, but 5 discrete skills. It might be appropriate, therefore, to change how we set the pass score for this to simply reflect that being very good at one maneuver may not make up for being deficient in another. In respect to the GI Mentor 2 versus the Mentor Express simulation platform, it doesn't seem appropriate to be penalizing people who use the Express. It seems like probably the study that suggested that was a problem, simply based off of the randomness of small samples, might have simply had a type 1 error there. Our time is limited to discuss a very important finding regarding the differences by gender, so I encourage you please to read the papers which give an extensive discussion of this issue, and also reach out to us as authors. We think this is an important conversation to continue. Very briefly, we'll say that it doesn't seem likely to us that the test itself is biased, but rather that it seems to be revealing bias in other aspects of training and surgery. And so, for instance, we link to a large body of research showing the biases that can be present in device design, such that they are much more usable for men than women, and also different experiences in the learning environment that equally capable women experience as opposed to men. And just to affirm, it does not seem likely to us, or at the very least, it's not detectable at this point, that there would be any inherent inborn differences in ability by gender. There are sufficient, seemingly, explanations for these findings based on systemic issues. As just one example of a systemic issue of concern, I encourage you to pause and just examine the difference in grip security and access to control surfaces for someone with a smaller hand, which tends to be women, versus someone with a larger glove size. Of course, there are plenty of limitations to this work. Most notable to me is that this is based on the data we have available, and there are plenty of other excellent validity investigations that could be conducted. I think especially response process evidence would be valuable, as well as an analysis of the consequences of the FES examination. Our findings are summarized here, which you can pause and review if you like. And I want to say thank you very much. And lastly, I'd love to encourage everyone, please reach out. We would love to discuss this work more with you and join with you as we try to help make assessment a part of ensuring fair, high quality training and performance of our trainees. Thank you so much.